In this session, I'm going to focus on the CLL in the Asia-Pacific region. Now, it's clear that CLL is rare in Asians compared with persons of the European or even the sort of Western population. And basically, these are some of the studies that we try to look into. For example, in some areas which we have different sort of ethnic population group, you can see that basically if you talk about Asian residing in California and Han Chinese, you can see that the CLL incidence was 5 to 10-fold less in Asian compared with the US counterparts. So you probably heard about that when Pat delivered her talk. She mentioned that CLL is the most common leukemia in adults, but this is only referring to the Western population. In sort of in Chinese or in Asian population, you can see that the CLL is actually pretty rare, okay? But however, it's been interesting to observe that there's been an increasing trend of CLL incidence in the Asian population. So you can see that in Asia, this is US men, in the US women, the incidence has more or less been flat, starting from the 1986 all the way to 2005. But it has been observed that in Taiwanese and also men and women, apologize for the color difference, but the Taiwanese men and the Taiwanese women, it seems that the incidence has been increasing. And also, we've seen that annual percentage change in the incidence of incident rate. You can see US is actually got minimal change. But in Korea, it has been reported that it's increasing by something like about 4% per year. We are still not exactly certain why that happens. Is it the diet change? Is it the lifestyle change? Is it the pollution or whatever? It's still not clear. The other things that we know actually quite clearly is that the Asians with CLL are generally younger than those of the European people. And you can see that in US, UK, and the sort of a median age at the diagnosis is around 70. In Japan, it's about 68, but in some other in Chinese or South Asian countries residing in UK, it's actually close to around 60 years old. So we may be about maybe 5 to 10 years younger in terms of the age at diagnosis. Another thing is that in this study, they have also reported that for some reason, the Chinese patient, if they got the CLL, they don't survive that well compared with the US patients. So you can see that the 5 years relative survival is about 60% versus about 75%, about 60% in Taiwan versus about 75% in US. 10 years survival, 45% in Taiwan, about 56% in US. So again, the disease appears to behave sort of less well in the Asian population. And also the disease progression appears to be more rapid in South Asians compared with non-Asian. You can see that the proportion of patients that doesn't require treatment actually dropped quite rapidly in the South Asian people residing in UK, comparing with the non-Asian sort of residing in UK. They actually need sort of the treatment a little bit later compared with the Asian population. So certainly there may be some genetic factors being involved. Okay. Let's talk about the problem of managing CLL in the Asian Pacific region. I think, as we have discussed earlier, Asia Pacific region is actually a very interesting area of the world because there are so many different countries. There's been so different socio-economic system and very heterogeneous healthcare system. And you can also see that among this Asian Pacific population, the genetics are also different. So I'm sure that you can see that the Chinese look differently from our Indian friends. And also in Asia, we're also something like Australia, which also got a big population of a Western population there. So overall, if you look at the region, it's actually not kind of a single or uniform kind of population. And all those difference in healthcare system, socio-economic system will also add some difficulties in our sort of overall strategy in managing CLL. And also, as I mentioned earlier in this conference, this is an area with huge populations. Okay, we have even if you talk about China and India, they are they have got the highest population among all the countries in the world. I've shown you this slide before. I just want to highlight to you that although there are many drugs that are available, but some of the agents, especially the newer agents, are not actually quite readily available in many countries in the region at this point in time, because they are, and also they are much more expensive. So we also have sort of may have difficulty in finding enough resources. And also, as I've mentioned, in overall, CLL has been regarded as an uncommon disease. So it doesn't receive actually enough attention, okay? And so there's been quite limited local or regional data. I've shown you data from Taiwan, I've shown you data from Korea, but we don't have a lot more data. We have some data from China as well. But overall, the data have been limited, okay, in terms of the epidemiology, the disease characteristics in the region. We know that it doesn't behave, the disease, those patients with CML in Asian region, they might not behave that well compared with the Western population. But how bad was the reason? Okay, we still need further studies. And the treatment outcomes, again, we're not sure because the treatment can be so variable. And the coverage for treatment, again, is quite variable. So we certainly need more data. And in fact, there's been relatively few research on CLL in the region, which I'm going to show you some snapshot, okay, of what's happening in the region. As far as my knowledge is concerned, I don't think there are actually very strong patient groups for CLL in the region. There may be some CLL groups here and there, but I mean the problem is that I don't see a lot of activities in the region. In Hong Kong, certainly we have adult blood cancer group, a patient group, and obviously they have a lot of people with acute leukemia survive that and then contribute to the activity of the groups. Under that, there is a CML concern group. Okay, when they first start as a sort of Gleevec concern group, as you can imagine, because they fight for the expensive treatment. But I don't think there are a lot of activities with CLL. Okay, compared with CML and other kinds of leukemia. So again, just like what I did with CML, I did a snapshot search using the clinicaltrials.gov and try to search all the active and recruiting study in Asia-Pacific countries. And I exclude studies which are multi-center, worldwide, that kind of things, okay? And you can see that there are not that many studies. We have 2 in Japan, we have 1 in Korea, and then another one is involve multiple centers, including Australia, Malaysia, China, Taiwan, okay? And but you can see there are actually more studies in China because they have actually got 4 studies in mainland China trying to test the newer sort of cell therapy. Not exactly a transplant, but cell therapy. There's been some new development over there. So what these sort of studies are they're actually mostly sort of focused on the treatment. Okay, so there's been 3 studies actually trying to evaluate what these agents that I've shown you. Mainly these are the approved agent. For example, in Korea, there have been a study testing the bendamustine, a kind of post-marketing surveillance, trying to look into the use of this drug. In China, they have been having this sort of rituximab plus steroid. For some reason, they put up a fresh frozen plasma. These are all these sort of established agents. The Jiangsu Province Hospital has put up a study. They're trying to evaluate the sort of effect of this treatment in ultra-high-risk CLL. And there's also another sort of study, this anti-CD52. I think they're actually there's a company in Shanghai making a biosimilar product, and they're testing the use of this product in patients with relapsed refractory kind of B-cell CLL. Of course, they have been also evaluating the treatment of CLL with new drugs. Okay, and in Japan, they are now studying the use of this proton tyrosine kinase inhibitor, ibrutinib, in subjects with the treatment-naive CLL or small lymphocytic lymphoma. There's a phase 1 study going. And although this drug has actually already been licensed in the US, but they're mainly for the relapse cases. They're now studying in the use as a first-line treatment. And also you can see that there are some also new drugs being developed. In Japan, they've developed a new drug. They're trying to study the use of it in a patient with CLL. There's also been a phase 3 study, again using the testing the ibrutinib versus rituximab in patients with relapsed or refractory CLL or small lymphocytic lymphoma. Ibrutinib has been, as I've mentioned, has already been approved in US and Europe, but as far as I know, there's probably not that many countries in the Asia-Pacific region with this drug being marketed. Even in Hong Kong, we're still waiting for the marketing. So there's a phase 3 study including Australia, China, Malaysia, and Taiwan, supported by the drug company. This is probably the interesting part because there are actually 5 studies currently ongoing in China. They're using this sort of CAR T cell, chimeric antigen receptor T cell. They're trying to target the CD19 positive malignant B cells, divide leukemia in lymphoma. And in other words, you can see that this is actually, they try to modify the T cells. As I've mentioned, the T cells are actually part of the army. They're taking a knife, they sort of trace up the cell, and hit them, okay? So what they're trying to do is that they modify sort of this T cell, they put in a chimeric antigen receptor so that this T cell, now they can recognize, they can approach, okay? Because this receptor is something that they can interact with the target. So they actually sort of catch the target and then try to sort of hit them and try to kill them. And there's been some successful story in the United States that they start using this CAR T cell and they have been able to treat, for example, a pretty young lady with acute lymphoplastic leukemia who have basically refractory to everything. And then they give this CAR T cell and they get because the tumor is sort of resistant to all the drugs. But then they put in a cell. Okay, I always said the cell is actually much clever than the drug. The drug is a molecule, whether antibody is something fixed. Okay, but you got a cell. You train up the cells. You modify the cell. You teach them. Okay, you have to target this, and then to get into the body, they start doing the job. And there's been very sort of like a miracle that we have actually sort of cured the disease in some refractory patients. So there's a lot of study ongoing in different parts of the world. And in China, there are quite a number of hospitals actually trying to study this concept in the treatment of various B-cell kind of leukemia or lymphoma. So in all this sort of protocol, they include not only lymphoma, but include CLL as one of the entity which they try to study there. So you can see that this immunotherapy or cell-based immunotherapy has become a very hit topic in the clinical research. And there are at least 5 studies going on. I'm sure there are more studies going on in different parts of the world and also different countries as well. Patient advocacy group is actually a very important component in our overall strategy of fighting CLL. And you can see that we have the CLL Patient Advocacy Group in Canada. This one is another CLL society with also some other, okay? And this is a patient center, okay, centric, physician, so curated nonprofit organization trying to support the patients. And I think overall, the problem is that as I've mentioned, I don't see a lot of patient group activity in the region for CLL. But certainly, we need this sort of a more patient support group in the region. The number one thing is that keep the patients connected. Okay, nobody is actually, if there's no group focusing on them, we can't sort of put them connected. And we also need to give support to the CLL or patient with similar disease called small lymphocytic lymphoma patients, as well as the carer, and to empower them. Because it's only through this patient group that we can keep them informed. Yes, as I've mentioned, there are a lot of new treatment being developed. And hopefully in the future, we don't need a bone marrow transplant, but we can have this sort of modified T cells, which can actually completely eradicate the disease. Because the cells are actually much smarter than the drug. We may not be able to achieve a cure with the drug, but we may be able to train up some cells to try to go in and target the disease. And we also have, like the CLM group has done, we can now have given the opportunity for raising the awareness, not only among the patient, but among the public, Okay, like now every year, September 22nd is the CML day. Now, but we don't have a day for CLL yet. Okay, so we are looking forward to such a CLL day in the future. Hopefully, that can also bring changes to the sort of overall care and also our strategy. And when I talk about strategy, it's not only about the physician. It's the overall the community's perspective. How we're going to find effective treatment, how we're going to fund all this expensive treatment, how can you sort of improve our diagnosis and also the monitoring. Okay, nowadays we got so sophisticated technology, and these technology are quite costly. You need to find money to actually help them. So at the end, the patient group for CLL, just like CML, may actually help to lobby for improved access to whatever sort of costly therapies or sort of monitoring strategy. Looking back the situation in the region, now if you talk about CLL patient group, CLL, if you overall you talk about the patients, they are actually a pretty good group of patients for a patient group because they survive quite long. As I mentioned, if you diagnose early, they survive more than 10 years. So if you have a disease which the patient survive for 1 year, so that means every year we have got the rising sun or rising moon meeting, you got a new batch of people coming in, isn't it? So, but you know, these people they survive longer, much longer, and they're now getting new treatments. So you are going to prolong the survival to almost forever. So in that sense, this is a perfect group of patients to organize them and to join them together and form a good patient support community. The problem, which I think right now, why there's a lack of a patient group in the region, is because number one, a lot of these patients, they may not have symptoms. They got a blood test, got high white cell count. You see a doctor, oh, don't worry, no, you don't have any symptom. So they don't have a lot of this sort of concern or of a problem that they want to seek help. Okay, and the other problem is that a lot of these patients, they are mainly elderly patients. Okay, so they may not have energy, or they may not have the ability. Okay, for example, you know that in the Western world, they put up a lot of this website. Okay, they draw the attention of the people, but if you do, if you look at the population in the region, I think maybe Malaysia, maybe India, maybe Hong Kong, a lot of these elderly people. How often do you think they go to have the computer, they log on, they search the website for information? The younger generation, they do. Okay, how often do you see the elderly people when they sit in the bus or they sit in the subway, take out the pad and start doing things? Okay. When you ask them, okay, when they take out the mobile phone, these are the mobile phone, very old style, very big, number pad, only show you the numbers that they dial when they make the call. Okay, how often do you see the elderly people using, wow, I got an iPhone 6S. Okay, so this is a different population. Okay, how to get them involved may be different compared with CML. That's what I think. Okay, and also we need to develop some appropriate educational material. You put up a website, it's only young people who look at it. Okay, maybe the son would like to look at it, but the patient probably never. Okay, so we need to have something, maybe a printed material, maybe something else, maybe a cartoon, maybe something like that, to help them to understand. And by the way, a lot of these elderly people, they may even have difficulty in reading. There are a lot of elderly people in Hong Kong. They didn't even have the chance to go to school, because that was the time when they have the World War, when China is chaotic. They haven't even learned. Okay, so how we can support them, how we can educate them. It will be extremely sometimes can be difficult, and it's quite variable among different countries in the region. So we may have to develop some action plan for the CLL patients, and then we may have to listen to the patient advocacy group from individual country and tell us what is the problem in the country, targeting this elderly group of patients, and see how we can actually sort of tailor-make the sort of program for individual sort of country or places. I think this is the end of my brief presentation. I welcome all your questions and comments. Thank you.
Okay, questions from the floor? Questions from the floor? No? I'll do it.
Well, maybe I can start one first. Are you ready to sort of start some activity for CLL? Now, I know this group of audience or participant, you all start your work with CML, okay? And I totally understand that CLL is probably new to you. And you can see that the disease is different. The symptoms can be different. The treatment, totally different, okay? The problem is, based on your understanding about, you know, your friends, your colleagues, or your other patients, maybe in the same clinic, under the same doctor with you, do you think there is a need that we have to do something for the CLL patient? That's the number one question. Because if we think, oh, there is a need, or there's something that we can do, then we have to determine what to do next. If you think that, okay, wow, CLL patient in my country is doing extremely well, number one, we hardly see any CLL patient. Number two, they're doing extremely well. They don't need any treatment, okay? They are even better than us. Yeah, then probably there's no need to do anything. But the problem is that although we say that CLL is rare in Hong Kong, and that's true, we don't have that many. We see more new patients with CML rather than new cases of CLL. Every year I see about maybe 12 new cases of CML. I saw probably around 6 to 8 with CLL. Okay, and a lot of them don't require treatment when they first diagnosed. So the spectrum is different. Okay, but because of long survival, I do have quite a number of patients with CLL. The number is more or less similar to the CML patient in my hospital. Okay, and every year I need to treat maybe around 6 to 8 of them, because you got 6 or 8 diagnosed new every year. At some stage they will progress to require treatment. So every year I need to treat at least 6 to 8 of them with the not so easy FCR treatment. Not to mention about the elderly people, they need other treatment as well. So from that perspective, from a clinician's perspective, a doctor's perspective, we do see some patients with CLL. I personally don't think, since we have done so much with CML, we should actually ignore the CLL group. The other perspective I'm going to briefly tell you is that I think 20 years ago, the support for CML is actually minimal because there's no treatment. Okay, 20 years ago, it's easy to treat CML. Transplant, no transplant. Transplant, go for transplant. No transplant, oh yeah, do whatever best supportive care, tender loving care. Okay, and all these things change with new treatment. Okay, that's why we have the CML group. We have in Hong Kong with the GLIVAC concern group. We have, and with all these new treatments coming, I think this is also an opportunity that we find some support, from the community, from the commercial side. We start doing something for the CLL. I think this is kind of partnership should actually, hopefully, ultimately can help the patients.
I don't know if it's a question more than a comment. I think from experience, as you were saying, Dr. Wong, that patients with CML go straight into treatment and have access to GPAP here. Patients with CLL that are watch and wait, they have very, very different psychological needs in what it means to deal with having a cancer and not being treated. And I think if you're thinking about expanding out to CLL support groups, that's a really important thing to keep in mind, that those two groups their needs can be very different.
Sure. Yes. Thank you.
I would like to actually, is that working? Yeah. Take a positive line on this, and we've had experience where we've had support group meetings for CLL patients, and we've had our volunteers and advocates from the CML group in the same way as we have support group meetings for GIST patients who also don't do necessarily as well as CML patients. And just having a group of CML survivors who look well, who are positive, who they're able to kind of bring some sense of hope and positivity, and I feel that that's something that we need to keep in mind, and as a group, So many of the people sitting here continue to undergo treatment for chronic myeloid leukemia. They present a picture that is full of inspiration, full of hope, and I feel that that is something that we really need to consider, that might give patients who are under treatment for CLL or GIST, for other cancers that are not as easy to treat and manage as CML. Maybe that would be, that would be a first starting point, which is why I think today in Rising Sun, we are open to including other cancers.
Well, certainly, I think building on the success of having a CML patient group, I'm certainly very optimistic about having expanding this sort of CML kind of patient advocacy group to a chronic leukemia kind of a patient advocacy group involving the patient with CLL. I also agree with the previous comment that if you look at the patient group, the CML, CLL, the psychology, and then the actual treatment, everything actually can be quite different. And also, we have to plan carefully. One very interesting thing I always told my CML patient is that this is certainly a chronic disease. But the problem is that this is a very special type of chronic disease, because the longer you treat, the better you'll be. Okay? Now, I mean, that's true, because you start with, tyrosine kinase inhibitors, you gradually achieve complete hematological response, cytogenetic response, your major molecular response, and even undetectable molecular response. You're getting better and better. And in fact, if you look at the side effect profile, most of the patients they start with, they have some side effect. Okay? But then with time, somehow they tolerate it better, and better. And like Dr. Ross has mentioned on Friday, there are some patients, even after you withdraw the treatment, they start to develop symptoms. Okay? And so the longer you treat, somehow the patient tolerate the treatment better, get a better response. It's quite different from other chronic disease. For example, you talk about diabetes. The longer you treat, the worse the patient will have. They have all kinds of complications. They get worse and worse. Unfortunately, the situation with CLL is actually quite close, because because usually with repeated treatment, the disease gets refractory, got more difficult to treat. And even the new drugs, even if you say it's interesting, because the longer you use, sometimes they got a little bit more side effect. Okay, this is quite different kind of things. So I'm optimistic, but we also need to prepare and plan, okay, for better kind of a program for them, because we do know that CLL is not exactly the same as CML. Okay, we have to take care of a group of patients who don't require treatment. Okay, they may have what they need is that they need to understand the disease. They need some form of reassurance. You'll be okay. Let's wait for some time. You may have 3 or 4 years that you don't need to get treatment, and then doctor will start you on treatment. So we need to educate to know that what symptoms they need to look for. No, not symptoms they need to report to doctors when they sort of every time they can go to the clinic, because you know that now busy public hospital contact time is so short. Okay, so a lot of time when patient come in the room, the doctor just asks, "Are you okay? Are you okay? If you're okay, that's fine. We'll see you 3 months time or 6 months time." But we need to educate them to see what to report. Okay, what are the things that they need to look for, and then if these are the things that they discover, they should report to the doctor, and that helps our job as well. So I think definitely we need to plan slightly differently, but I think overall I'm quite optimistic. Thank you.
But
I have a question, and maybe Dr. Harris will address it later, but we haven't talked about infections and the role of infections on CLL patients too much. My understanding was that a lot of patients die of infections. So I think that's important in the context of meetings. Can they attend meetings, or are they immunocompromised all the time?
Well, certainly. I mean, at the as I've mentioned, some patients, even if they have quite earlier stage disease, they got this sort of funny infection like the shingles, a bit more. And also by the time they reach sort of the terminal stage of the disease, a lot of them actually got quite bad infection, and that caused the death of many of them. But because you're looking at the overall, the natural history may spend for 10 years or even longer. I mean, obviously not that patient has got severe infection right from the beginning, and not that many of them are so immunocompromised. And we also have ways to help them. Like, for example, we can replace the antibody. Okay, that will help them to control infection. So that's not an absolute reason that we cannot form a patient group, but we definitely need to bear that in mind.
But it's possible to have meetings, and it's possible for them to attend meetings.
Yes, most of our patients, they live normally.
Right. Okay.
Okay, so I'll try to summarize the whole session for the Asia Pacific region for CLL with this question, doctor. If a patient comes to the hospital on a Monday, gets his laboratory test results Tuesday, he has CLL, okay, but asymptomatic, okay, but the test result says he has CLL. He goes to you, knowing and having presented to us all of the branded medicines that's probably of Western origin, and that all of the China ongoing clinical trials and all the others, all of these combined, what would you tell an Asian patient on Wednesday?
Well, basically, I think apart from the diagnosis, we also need to evaluate what stage the disease is and what are the symptoms of the patient, and determine whether they need treatment. So I mean, based on all this information, then we can do the counseling, okay, education and counseling, and then telling the patients, okay, what do we expect about the sort of the outcome. Okay, how long we expect the survival, you know, whether we think the patient will need treatment or not. And in that case, if the patient really need treatment, we'll discuss all the treatment options. It has to be individualized for individual patients, okay? Because every patient is different, okay? This disease, how bad the disease is different. What's the overall general condition of the patient, whether they can tolerate various treatment is different. So we do individual patient education and counseling. Okay, and so by the time we have all the laboratory results available, we will talk to them in details about the disease, what are the treatment option, what can we do, okay, when do we want to do something, what do the patient have to look for, to monitor himself or herself, and what are the possible outcome. That's what we'll do.